So here we're going to talk about the therapeutic effects associated with some of the small molecule neurotransmitters that we've looked at in detail. So this gets to what kind of drug effects are going to affect these particular neurotransmitters. And one of the things is that many drugs for neurological disorders are going to target these specific small molecule neurotransmitters. So one thing that I've done is also included the structure since we worked through those in class. And I wanted to make sure that you are seeing the name of the neurotransmitter along with the structure of it. So here we have glutamate. And one of the things, or some of the disorders that are associated with glutamate are ALS, which is short for amyotrophic lateral sclerosis, also more commonly known as Lou Gehrig's disease. And for those of you who are around during the Ice Bucket Challenge, that was a way to raise money for that rare disorder that doesn't really have a cure. There are some issues in glutamate signaling in Parkinson's disease and also Alzheimer's. Parkinson's also has a dopamine deficit, and Alzheimer's, there's many other things that are going wrong in Alzheimer's as well. But glutamate is one therapeutic target that we can look to ameliorate some of the symptoms, right? We're not going to cure it, but we can help with the symptoms. And so one drug that is going to do that is riluzole, and it is a voltage-gated channel blocker. And so basically it's going to stop the release of glutamate. And specifically glutamate that's going to bind at postsynaptic receptors that are NMDA receptors, which is in the receptor part of the content, which is coming up next. And it can moderately help with ALS. But like I said, it's only going to moderately ameliorate the symptoms, and it's not a cure. Another drug is memantine, and that is an NMDA receptor antagonist. So basically, with these disorders where there is the excess glutamate, we just prevent glutamate signaling. And so memantine as an NMDA receptor antagonist has been shown to decline the symptoms of Alzheimer's. And as we go through the course, one of the things that we'll see is that memantine can also possibly decrease symptoms of depression as well. Because we used to think the depression was all serotonin, and now we're starting to see that other neurotransmitters like glutamate are involved as well. So riluzole, memantine are targeting glutamate, and in this case they are inhibiting glutamate activity, so they are both glutamate antagonists. And if we remember from the previous lectures, so glutamate is the primary excitatory neurotransmitter, and GABA is the primary inhibitory neurotransmitter. But if you were just looking at the structure of glutamate, one thing you'll notice is that GABA is really similar, but instead of 5 carbons, GABA has 4. So for those of you who have had the fortune of not taking organic chemistry, any little peak is a carbon. So this is 1, 2, 3, 4 carbons. And then this group here, you don't have to know this, but this is just a carboxyl group. So double bound oxygen and an oxygen and a hydrogen. And then you have an amine group. So you have a carboxyl group over here and an amine group, which makes these amino acids. So glutamate and GABA are part of the amino acid neurotransmitters. And the structure here is just smaller than glutamate. But if you compare the structure with glycine, which has a different precursor, it only has, I think it has 3 carbons instead of 4 carbons. So glutamate, GABA, and glycine are all structurally similar, but have different effects. And so GABA receptors, this is in one of the videos, but GABA receptors, when they open, they allow chloride in, and that makes the inside of the cell more negative. So that's going to inhibit the cell. So that's what normally happens. And when people have anxiety, they basically don't have enough inhibition. So their brain's too active in certain areas. And so in order to target anxiety, we use benzodiazepines which bind to GABA receptors, specifically the GABA A receptors, and increase the function of the GABA A receptors. So there's going to be more chloride coming in, and so then you're going to have inhibition, and so in kind of thinking of like decreasing your anxiety. So increasing inhibition and decreasing the anxiety, and specifically in areas of the brain that are responsible for fear, so like in the amygdala. And in addition to using it as an anxiety medication, you can also use it as muscle relaxants, anticonvulsants, and sedatives, because it's going to kind of shut everything, that brain activity down. And then, and those are agonists, right? So everything we're looking at here are agonists to GABA, increasing that inhibitory signal, whereas the ones above were glutamate, and those were antagonists for glutamate to decrease the excitation. So alternative to benzodiazepines are barbiturates, that's thiopental, pentobarbital, and methoxidol, also GABA agonists, and those are often used for anesthesia. And one of the interesting things about that is that there's regional variation in the expression of the different receptor subtypes in different areas of the brain. And so you can get regional variation for anesthesia in different areas of the brain because of those different receptor subtypes. And when we look at acetylcholine, it's one of the structural ones that does not fit anywhere else. It doesn't not go into a group. But one of the things that you can remember is that you have this choline group over here, and then you have this bound to acetyl-CoA. So acetylcholine. And when you see the nitrogen surrounded by carbons, then you just remember that that's acetylcholine. And two drugs that are going to be antagonists for acetylcholine are hemicolinium, and that just blocks the choline transporter. This is a little bit different than what we have kind of seen before. So in our generic signaling mechanism, we said that, okay, anything that's going to block the reuptake or those transporter proteins is going to keep the neurotransmitter in the synapse longer. However, one of the things that happens with acetylcholine when it's in the synapse is it gets broken down by acetylcholinesterase. And so if the bits don't get back into the nerve terminal, they can't be built again. And so even though this one is blocking the choline transporter and keeping it in the synapse longer, the acetylcholinesterase is still breaking it down. So even though it's in the synapse longer, because it's not able to get back and get remade in the nerve terminal again, it is an antagonist. And botulinum toxin, or Botox, also is going to prevent the release of acetylcholine in very complicated ways. And it depends on what type of protein that it's going to be bound to, and there are different types of toxins. So this gets way more complicated. But one thing to think about, if you think about individuals who get Botox injections, their face is basically doesn't move. So that's the quote unquote benefit, is that you can't move your muscles in order to develop the wrinkles that are associated with those muscle movements. So the next neurotransmitter that I have here, I know on your handout it has norepinephrine first, but I don't know why I did that. I want to do dopamine first because that's the precursor for norepinephrine. And you'll notice that for dopamine and norepinephrine just has an extra hydroxyl group on there. And we've talked about dopamine involved in drug and reward pathways. But one of the things that is disrupted in schizophrenia is levels of dopamine. So really too much dopamine can lead to the symptoms of schizophrenia. And so most antipsychotic medications are going to target dopamine receptors. But some of the original antipsychotic medications targeted specifically the D2 receptors. But because D2 receptors are involved in other things, there are some pretty severe unwanted side effects. And we will get into that when we get into the schizophrenia section. But some of the new generation antipsychotics So like clozapine, it has a greater affinity for D4 receptors. It still binds D2 receptors, but binds D4 receptors better. And as a result, can have fewer side effects. So specifically using differences in like mild drug structures that are going to target different receptors can improve the activity or the benefits of those drugs. When we look at norepinephrine, we see that it's very similar in structure to dopamine because dopamine is the precursor for norepinephrine, and the enzyme that's going to change dopamine to norepinephrine is just going to add this hydroxyl group right here. And so norepinephrine is involved in the fight-flight response. And so there are drugs that can mimic the response of that fight-flight response happening from the sympathetic division of the autonomic nervous system. And those are sympathomimetics, like amphetamines and ephedrine. So those ones are just going to increase that fight-flight response. And specifically, one of the things we'll look at, that amphetamine can be used to treat ADHD. We'll look at those medications, how they target norepinephrine, but sometimes can be addictive because dopamine is the precursor to norepinephrine. And so the newer ADHD medications that target the receptors instead of the neurotransmitter itself have less addictive effects and more specific effects to help mitigate the symptoms of ADHD. So medications are getting better as we learn more. And now we've got our last one. So 5-HT is just abbreviated for serotonin. So thanks for sticking with me to this last one. And one of the easiest ways to identify the structure of serotonin is just has the double ring structure. So it's the only one that has 2 rings, and so it's easy to identify. And the drugs that are going to target serotonin, specifically for depression, are selective serotonin reuptake inhibitors. So now these are the ones that are going to block the reuptake transporters for serotonin so it doesn't get back into the nerve terminal, so it stays in the synapse longer. And unlike what we saw for acetylcholine, serotonin doesn't have an enzyme in that synapse that's going to break it down. And so it stays there longer and it's able to activate those serotonin receptors longer. So SSRIs, common ones are fluoxetine, Prozac, which I think is just a the brand name for fluoxetine. But one of the things, and I talk about this all the time in many of my classes, is that they're going to work for typical depression, but not everybody has typical depression. So there are other causes of depression that don't have a serotonin cause. And so for many individuals, this does not work. So I don't know the exact percentages anymore, but it's like and it depends where you're looking, but anywhere between 40 to 60% of individuals do not respond, or individuals who have depression do not respond to SSRIs. Some people who do not respond to SSRIs will respond to monoamine oxidase inhibitors. So those are MAOIs are like phenelzine and selegiline. And so those sometimes work for atypical depression. They don't always, but they do have more side effects because one of the things is that the monoamine oxidase inhibitors inhibit monoamine oxidase is the enzyme that breaks down serotonin, norepinephrine, and dopamine. So if you inhibit that enzyme, you're going to have more serotonin, norepinephrine, and dopamine. So it's more of like a shotgun approach where you are increasing multiple neurotransmitters that are related to mood, whereas the serotonin is more selective only for serotonin. So this was the original treatment for depression. But a lot of side effects because it's affecting so many neurotransmitters. So then when they came with selective serotonin reuptake inhibitors and it worked for some people, they were like, yay, we solved it. But then they didn't actually, because there are still some people that does not work for. And then one more, bupropion is one of the newer atypical antidepressants, and it works by increasing both dopamine and serotonin. And I think I'm going to stop there because we're getting into 15 minutes. And this is what we would have done in lecture. Welcome to pause it and go make sure your notes are complete. But these are just some examples of drugs that are going to target those neurotransmitters that we've looked in detail at.